So I've been asked to go through some cases dealing with the spinal cord and the spine. And I think most of us reporting MRI out there will be very comfortable with the things we see commonly, all of the compressive myelopathies from disc disease, even MS and the odd tumour, trauma. So where we tend to exit our comfort zone rapidly is where we come across the uncommon conditions, the weird-looking conditions, and the unhelpfully non-specific imaging finding type of conditions. So I'm going to start off by looking at a case of basically a positional myelopathy and compression with no evidence of compression on your initial imaging. I'm going to go through a group of cases which have an initially, at first glance, similar appearance but entirely different pathologies. These two fit into the slightly uncommon group, but they're both treatable. So they're important conditions to know about to enable a patient with a potentially devastating outcome to be treated and instead have a good outcome. And then I'm going to embark upon a few cases which is the non-specific finding of long segment T2 hyperintensity in the cord, which unfortunately has a very large differential list and very few imaging discriminating factors. So I'm going to look at my approach to how to deal with that. If we have time, there's a bonus case at the end. So our first case is a 30-year-old male. He has bilateral hand and forearm wasting and weakness, and the clinician was worried about a denervation type of injury. So he came in for the routine non-contrast MR sequences, and the striking abnormality here is this quite pronounced atrophy in the lower cervical spine with associated T2 hyperintensity. There's importantly no disc disease or compressive lesion. And on the T2 weighted axial sequences, you can see that a lot of this T2 signal abnormality corresponds nicely to the anterior horn cells, and you also get a really nice look at the atrophy, thinning of the cord. So clues to the diagnosis here. First of all, there's the clinical picture, bilateral upper limb motor changes, and this location of abnormality. You might start thinking chronic myelomalacia from, say, previous MS, but really the location distribution is pretty unusual for that. Previous compressive myelopathy you could think about, but there's no evidence that this person has had significant disc disease in the past or any intervention. We have heard about a few causes of anterior horn cell predominant signal abnormality, but really this isn't an acute presentation of ischemia or any of those infective causes of anterior horn syndrome that we've heard talked about. So really the findings are quite suggestive of Hirayama disease. Hirayama disease is a compressive myelopathy that is positional. So if you do an MRI scan in the flexed position, if you do an MRI scan in a position of flexion, what you can see is that the posterior dura has migrated anteriorly. There's a pseudomass behind it, which basically is the engorged posterior epidural space with a lot of prominent flow voids, so that is due to passive engorgement of venous plexus. If you give contrast, in fact, this will enhance vividly. And what this anterior migration of the dura does is it compresses the cord up against the back of the spinal column and causes compression, and that's the source of the atrophy and myelopathy. So this is actually a fairly classic end-stage case in a patient who's 30. Now the classic presentation is late teens, early 20s, and it's a progressive disease that worsens in severity over 3 to 5 years. And this is probably at the end stage. I don't think there's much you can do for this patient at the moment. The time when you need to pick this is before the myelopathy has gotten to this stage, and at that point the imaging findings can be much less pronounced. So what I would suggest is that if you've got a patient who has a classic clinical story, the right age group, the right clinical findings of bilateral, usually asymmetric upper limb weakness, it's actually probably worth doing a flexion MRI if you haven't found any other cause. Other cases where the clinical history isn't quite as suggestive, or where you don't actually have such good clinical details on your referral, if you do see in that lower cervical cord some particularly asymmetric, subtle atrophy in the absence of any identifiable cause, that would be another clue that it might be worth getting some flexion MRI sequences. So the next group I would like to talk about is a group of patients who present with some form of myelopathy, and on initial imaging, the thing that you most notice is that the posterior CSF space is enlarged. Now, these three images look pretty much the same, they look very similar, but actually these are three separate conditions, and they're conditions which are all treated surgically but through different approaches. So it is important to try to identify which of these is involved based on the imaging to assist the surgeons. So I'll start with the first case, a 29-year-old female. She's got quite a long background history of 10 months of lower limb weakness on the right, but over the last few days she's started to develop sensory changes in the contralateral limb. So usually we start off, or I start off with the T2 sagittals, and when you start off in the midline, really looks fairly normal. If you look a little bit closer, in this area here, and I'll show you a close-up, you can see that there is actually an anterior kink in the cord. You can see that the posterior CSF space is enlarged. And interestingly, you can see that there's a chronic-looking old compression fracture at that particular level. So if we take a look on the axial T2 sequences, you can see that above the level of abnormality, we have a fairly normal-looking cord, normally positioned within the spinal canal. Start scrolling down, and it's being displaced anteriorly and toward the left, and kind of almost rotated. And you can see that the shape of the back of the cord is kind of almost pinched off towards the anterolateral aspect on the left. And as we keep looking further down, you can actually see that that whole left hemichord is abnormal. It's slightly reduced in volume, and it's got definite T2 signal hyperintensity. So there was no enhancing lesion and no evidence of signal abnormality elsewhere. So we've got a couple of things to think about. We've got the cord abnormally positioned. So is that pushed forwards from behind by a mass, such as an arachnoid cyst, something CSF signal that's hard to identify? Or is it somehow tethered anteriorly, either by adhesion or what I think is going on in this case, which is a ventral cord herniation? So there's a couple of clues. One is the way, so these cord herniations do tend to be a little bit off midline, and so they do tend to have that really distorted and rotated appearance. The kink tends to be quite focal, and it's this nice C shape as opposed to a more gentle curve in some other pathologies I'll go into later. And one of the key findings to help us determine that there's probably not something behind going on is that there'll be no change or alteration focally in the CSF loboids posterior to the cord. So I'm going to contrast that with a couple of different cases. So again, we have an abnormal contour to the cord. There is this spot here where the posterior CSF space is enlarged. The cord itself looks quite abnormal as well, in the sense that there's this cystic focus in the cord, as well as that focally thinned or compressed area immediately superior to it. Now, at first glance, you've got a cystic lesion in the cord. You might think, look, is that a mass? Is this a tumour? So there's a couple of things which would point you away from that. So one, there's no enhancing lesion related to that. The other is that really, although this bit you could argue that is actually a bit expanded, this bit here is thinned. And I have to say I've not really seen a mass tumour that causes focal thinning, particularly in the absence of evidence of previous treatment. If there'd been surgery in that region, you should be able to see the laminectomy defect and the abnormality in the overlying subcutaneous tissues. If there's radiotherapy, often you get a good clue to that by seeing fatty replacement in the adjacent vertebral bodies. Could it be ventral cord herniation, which is what we thought the previous case was? There's one really big problem with that as a diagnosis, and that is you can see that the anterior CSF is maintained. So one of the keys is that if you've got a herniation of cord through a defect in your ventral dura, obviously you're not going to have CSF then between the dura and that herniation. So that leaves us with two main differentials here. So one would be the dorsal arachnoid cyst, which we mentioned as a potential differential for our previous case. But really you get a nice maintained flow void all the way through there. And so the final thing to consider is a dorsal arachnoid web. So there are two findings here which helps point us in that direction. So one of the signs for a dorsal arachnoid web is said to be the scalpel sign. So the idea is that the shape of the focal indentation of the cord has a shape like an upside down scalpel blade. The other thing that's a useful associated finding that's not necessary for the diagnosis is the presence of the syringomyelia, which is present in probably more than half of the cases of dorsal arachnoid webs. So that's a nice supporting finding. So for the third of the pathologies that give rise to a similar appearance, this is kind of a pre-case rather than the one I want to talk about in more detail. So the third pathology is dorsoarachnoid cysts, and these can be extremely subtle, and you often have to suspect the diagnosis so that you can go on to prove it. So this is actually an arachnoid cyst, which is an obvious finding, displacing the cord posteriorly, thinning it. And this one's nice because you can actually see a cyst wall coming around. So I'm just going to contrast that to this case, which is similar to our previous two cases where we've got anterior displacement of the cord and we've got an enlarged posterior CSF space. Like the case immediately preceding, there's preservation of the anterior CSF in front of the cord, so it's not going to be a ventral herniation. The shape of that indentation really doesn't look like that scalpel sign from the dorsal arachnoid web. And there's no syringomyelia. What we do have that's a useful finding is this. So this is our indentation of the cord. So if I just show you this kind of outline here, can you get the impression that there's kind of brighter CSF in that area where the flow voids are interrupted. So that's a good indicator that there's actually something of CSF signal sitting in there causing the compression and anterior displacement of the cord. Now to prove that, there's a couple of options. One thing you could try is doing a high resolution T2 weighted scan like a Fiesta or CIST through the region to see if you can get a better delineation and can identify a cyst wall. Another option would be to do some cine flow studies and better demonstrate that alteration of the CSF flow. The next option is a little bit more invasive, but gives you a pretty picture. So a CT-guided myelogram. This is this patient showing contrast that's been injected intrathecally, you can see you've got a slightly different density outlining that rounded arachnoid cyst with a dependent level. So a nice proof of the diagnosis. So in summary, these three conditions which look fairly similar at first glance. The first condition, the ventral cord herniation, you must have loss of that anterior CSF. The others, occasionally it does obliterate the anterior fat plane, but that's just because of the size and severity of the displacement rather than part of the actual pathogenesis. The cord is rotated around rather than more symmetrically anteriorly displaced as in the other conditions. And you get that C-shaped kink in the cord, which is quite focal. The other thing that's helpful is that the most common clinical condition that this gives rise to is actually a hemichord deficit, like in the patient whose case we saw, a Brown-Séquard syndrome. Of the other two conditions, paying close attention to the CSF flow in that enlarged posterior epidural space will point you towards the dorsal arachnoid cyst. And the scalpel sign is what's considered to be a useful indicator for dorsal arachnoid web, with the preservation of the anterior CSF being helpful in discriminating it from a ventral cord herniation, and syringomyelia being a supporting finding. So from there, I'm going to move on to probably one of the most difficult of the conditions that we face as a diagnostic dilemma. And that is when you've got longitudinally extensive T2 hyperintensity of the cord, a myelopathic patient, and essentially you've got a very long differential which runs the whole list from vascular to infective to inflammatory to neoplastic causes. Not that many discriminating imaging findings, and usually you've got also a patient who's got a devastating neurological deficit, and the surgeons are keen to start some sort of treatment. Sorry, not surgeons, the neurologists are keen to start some sort of treatment soon to maximise the chance of a good outcome. And so the main problem is this. So this isn't even an exhaustive list of the differential diagnosis for this imaging presentation. And as I said, it involves all of the spectrum of different pathogenetic backgrounds. So what do we do? Now, I like to think about this as one of those areas where you actually need to not just rely on the imaging, but it's really helpful to get a bit of extra information. So the clinical info, of which the onset time is very helpful, and the presence of any additional symptoms or background history. Usually at the time you're doing imaging, there's at least a full blood count, possibly an ESR, and often you'll have access to the results of a basic CSF analysis. So once you've looked for all of your imaging clues as to specific diagnoses, then you can start using these to cull down your differential. And if your referrers are anything like ours, I usually like to make a phone call. That's got a few benefits. One is that you can discuss the pros and cons of various things that you're considering based on the imaging. And the other is that they know then that you've asked the intelligent questions, are interested in the case, and then you get a bit of feedback about the result once the definitive answer comes in, sometimes in a couple of weeks. So systematic approach is always helpful. When you've got such a broad list, you want to be able to have clinical features that you can use to narrow that down and weight your examination. There are some imaging clues which lead to specific diagnoses, particularly some of the ones which are not steroid responsive and that perhaps require some other treatment. And the other thing just to bear in mind from Prameet's talk, just because we're asked to examine the cord doesn't mean that that's the only spot that the pathology can be affecting. And it's an important part of the examination to look at the imaging of the brain. So if we've got this big, long differential list, I actually like to think about it slightly differently. I like to think about it in terms of how rapidly the progression has occurred. Basically, if you've got a very abrupt acute onset, less than 4 hours to nadir, that's when you can really think that that's going to be a cord infarct, ischemia. Then the days to weeks is really that group of transverse myelitises. And then if you've got a more chronic course, you start thinking about some of the other vascular causes, possibly infiltrative tumours, metabolic and paraneoplastic conditions. From there, any other clinical features can be used to help you work out what you think is going on and the most likely diagnosis. So with the clinical features in mind, then we can start doing our job as a radiologist, which is to look at the actual imaging. So characterising the location, as Pramit has talked about in his talk on inflammatory conditions of the cord, is extremely helpful. So looking at the location in the cord, what columns are involved, whether it's the entire cross-sectional area. Then looking at the enhancement pattern, because some features are actually useful in narrowing the differential diagnosis. The most obvious one is the vascular flow voids, which might point towards a dural AVF. But also if you've got leptomeningeal enhancement and nerve root enhancement, that can actually point you towards specific types of conditions like infections, sarcoid, lymphoma. And the next step is to have a look at the brain to see whether there are any disease-specific features, for example, demyelination or of particular types of infection. So I've just put together some of the figures from Pramit's talk, just a reminder of what locations we're looking at. So MS we're pretty comfortable with. Dorsal column involvement, B12 and copper deficiency. If you've got, say, dorsal lateral column involvement in a patient with HIV and a long history of onset, you might think vacuolar myelopathy. And then there's anterior horn involvement, which might point you towards either an ischemic event or one of these poliomyelitis-like syndromes. Although, unfortunately, most of them in this group are going to have this appearance with the large, broad differential diagnosis. So first case, it's a 31-year-old female, 4-week history of ataxia and sensory change. And what we have here is a fairly longitudinal extensive T2 hyperintensity, cervical down into the thoracic region, and on axial sequences demonstrates quite nicely that kind of V-shaped involvement of the dorsal columns. So that distribution is pretty suspicious for a B12 deficiency or subacute combined degeneration of the cord. There is a differential, so subacute combined degeneration of the cord can be from B12 deficiency but also copper deficiency. The other thing just to bear in mind as a possibility would be Tabes dorsalis from the syphilis infection. So, but this case had a low B12. And actually the other thing I should mention, this is the classic appearance for the subacute combined degeneration of the cord. In really florid cases, you can actually have slight lateral extension of the signal abnormality. And in very florid cases, sometimes the signal abnormality can extend superiorly up into the brainstem. So those sorts of findings shouldn't preclude the diagnosis. Our next case is a 45-year-old female. So she'd had a recent epidural anaesthesia. She came to us because of new onset urinary retention. And in fact, she started off having an MRI of the lumbar spine because they were concerned about an epidural hematoma causing compression. But the lumbar spine MRI actually just caught the bottom of the conus, which was expanded in T2 hyperintense. So the patient was brought back to have the rest of the cord imaged. And this shows extremely extensive T2 hyperintensity. Basically involves the entirety of the cervical and thoracic spine, which is diffusely expanded. And on the axial sequences, that just shows the extent of the involvement using more than 2/3 of the cross-sectional area of the cord. And on post-contrast imaging, you can see that there's multiple areas of diffuse and patchy enhancement. No leptomeningeal or nerve root enhancement. So this is kind of your archetypical longitudinally extensive cord lesion. Fairly broad differential diagnosis. In this age group, female, 45, in the absence of fever or other prodrome, I think really demyelination is probably one of the first things we considered. Now this distribution and the extent of the lesion would obviously be unlikely or atypical for MS. But what we did was go on to image the brain. So on the flare sequences, we can see this periventricular hyperintensity, which is a little bit unusual for MS. We're used to seeing periventricular lesions, but there tend to be lots of smaller foci and that perivenular Dawson's finger appearance. And the other thing is that there's really no juxtacortical or even subcortical lesions here. And this, if you remember from the earlier discussion, in the periventricular region and the periaqueductal grey area, these are areas where there are high levels of expression of the aquaporin 4 water channel receptor, which is the target of the autoimmune channelopathy that is neuromyelitis optica. So the combination of a longitudinally extensive cord lesion, these sorts of brain lesions, or say hypothalamic involvement, would point you towards neuromyelitis optica as the culprit. And indeed, this patient had positive NMO serology. Our next case is a 64-year-old male with 8 weeks of lower limb numbness. So the T2 hyperintensity is less extensive in this case. It involves much of the cross-sectional area of the cord, from the conus up about 4 or 5 segments, maybe a little bit expanded, but the cause of this, there's a clue on this image, which is these prominent flow voids. Now, we had a beautiful case earlier shown to us from Ranil Chandra of possibly the largest fistula I've ever seen, with really extensive cord signal abnormality. And they're not that hard to pick when you've got gross flow voids all over the entire spine. These ones are also important, though, to keep an eye out for. Because this is definitely more than you'd expect. And in the context of this conus signal abnormality, very, very suggestive of a spinal dural AVF, which, as has been pointed out, is a readily treatable and reversible cause of myelopathy. So in this one, we went on and did a contrast enhanced MRA, which shows this smallish cluster of tangled vessels, probably being fed from the left here, which we thought was going to be T12. And this was confirmed at spinal angiography, showing the fistula feeding that tangle of abnormal vessels. So this is a spinal dural AVF with relatively subtle cord changes and these small abnormal flow voids. So our next case is a 37-year-old male. 4 days of weakness, fairly acute in onset, hyporeflexic, and has a background of a diarrheal illness. And so in fact we were asked to do this to look for nerve root enhancement to confirm the clinical diagnosis of Guillain-Barré. But actually what we found was a cord abnormality. So you can see that there is long segment T2 hyperintensity, centrally reasonably thin, all through the cervical cord and very subtly coming down into the thoracic cord. When we look at this on the T2 sequences, we can see that the signal abnormality actually corresponds to the anterior horns. There was no abnormal contrast enhancement in these regions. So anterior horn T2 hyperintensity has a differential. So these areas are metabolically active and at risk for ischemic insults. But this particular patient didn't have an abrupt onset. It was a progression over a few days. He's a bit young for most of for the cord infarction, and he has this history of a febrile illness. So the other alternative for these T2 hyperintensity specific to the anterior horns is one of these viral myelitises, which preferentially attacks the anterior horn cells. So polio, although we don't actually see that in Australia very often, enteroviruses and flaviviruses. And I actually think it was the joy of working in the same place. We've both seen this patient and clearly both reported on him. And so this actually is an MRI done at a similar time, showing that peripheral flare hyperintensity all the way through the brainstem, but no thalamic signal abnormality. So a lot of these viruses that attack the anterior horn cells can also present with rhomboencephalitis or a coexistent rhomboencephalitis and myelitis. The flaviviruses like Japanese encephalitis, those sorts of things have a tendency to be associated with thalamic signal abnormality. So those are other additional features that you can look for. So another case is actually a patient with non-poorly controlled SLE. She's a 24-year-old female. She's in acute urine retention on a 5-day background of progressive lower limb weakness. So with that kind of clinical history, my initial thought is that it's going to be either NMO or SLE myelitis. So we have a look at the imaging. And we've got long segment T2 hyperintensity, cervical as well as thoracic cord. On the T2 sequences, in some areas we've got kind of patchy asymmetric signal abnormality, but most of it is fairly central grey matter predominant. So really quite a non-specific appearance. It's that real transverse myelitis look. However, on the contrast enhanced sequences, you can see that there's all this leptomeningeal enhancement, even up into the posterior fossa, without convincing enhancement within the cord itself. So these demyelinating conditions, NMO, don't tend to be associated with leptomeningeal enhancement. The autoimmune inflammatory type conditions like SLE and also infective conditions are the sorts of things which I'd be thinking of when I see a transverse myelitis looking cord in association with leptomeningeal disease. The other things which can cause kind of leptomeningeal and nerve root enhancement are things like sarcoid. In this case, given that we know that they have SLE, that's the most likely thing is SLE myelitis. And indeed, that this patient was found to have elevated ESR and those inflammatory markers. And she was treated for an SLE flare. Okay, so this next case is a 40-year-old male. He presented febrile with a headache and confused and had a normal-looking CT brain in the ED department. However, the real concern clinically was a new sensory level at C5 with upper motor neuron signs in the upper limbs, as well as lower motor neuron signs apparently in the lower limbs. So this gentleman had an MRI through the cord showing this T2 hyperintensity in the cervical cord, some parts central, but also these more patchy peripheral areas of T2 hyperintensity. And there are patchy areas of enhancement in the cord, particularly peripherally. So all this kind of thick and irregular leptomeningeal enhancement. Now the other thing that we noticed on the MRI is that there's these funny enhancing spots in the cerebellar hemispheres, bilaterally actually, which in retrospect on the T2, you can actually see that's T2 signal abnormality and a bit of mass effect. So imaging appearance in the cord actually looks quite a lot similar to the previous case. We've got central as well as patchy peripheral, long segment T2 hyperintensity. We've got extensive leptomeningeal enhancement. But in this case, rather than a history of SLE and elevated ESR, what we're looking at is a febrile, unwell presentation. So although the differential diagnosis is similar, we've got infective versus autoimmune versus sarcoid, we're really looking at the infective causes here. CSF analysis at this time showed increased polymorphs and increased protein. So this was consistent with a bacterial infection. And this patient also underwent brain MRI, which was quite interesting. There was a delay between the spinal MRI and the MRI brain because the patient deteriorated with hydrocephalus, had an EVD put in, as you can see. And we've got this periventricular hyperintensity, as well as hyperintensity in the splenium. And in those areas which we previously noted to be contrast enhancing. Now that contrast enhancement has essentially resolved about 5 days after the initial MRI spine. And if we look at the DWI, so there's actually focal areas of diffusion restriction in the splenium, as well as the periventricular areas, and some punctate foci of cortical as well as cerebellar. So what we're looking at here is multifocal areas of ischemia, as well as some intraventricular diffusion restriction, which is suggestive of pus. So that all fits together quite well as a bacterial meningoencephalomyelitis, probably with infarction secondary to the infection, either mediated by DIC or through inflammatory vasculitis. And this person actually had pneumococcus isolated from their CSF. So I've looked at a series of cases which I've grouped into particular imaging problems. With the T2 hyperintensity, it comes to us often as an undifferentiated, non-specific looking thing on imaging. What you need to do is identify pathologies that aren't optimally treated with immunosuppression, because the reflex of the clinician is going to be to give steroids until they work out what's going on. So things which require surgery for treatment, like spinal dural AVF, are not going to get significantly better on steroids. And really it's the radiologist's role to identify the chance of that and to organise the further imaging with MRI angiograms and usually catheter angiography to really make the diagnosis. It's also important to start off by ruling out a compressive lesion, which needs to be treated surgically. And when we're going through some of these signs of specific etiologies, some of them point to infectious causes, which may not respond all that well to hardcore immunosuppression. So it's helpful to pick out those cases as well, so that the treating doctor can maybe fast track some of the tests and get them on the right treatment earlier. Now, we've got just one short case that I'm just going to finish with. It's interesting pictures. It's a 49-year-old female who came in with a couple of weeks of postural headache. And I'm just going to show you the spinal imaging first. So if we look at the sagittal T2 sequence, you can see the cord itself looks pretty normal. But then there's this unusual double appearance of T2 hyperintense stuff peripherally, then dura, and then T2 hyperintensity in the intradural space. And this continues all the way through the thoracic as well as the lumbar spinal canal. And if I show you on the axial sequence, so this is an axial T1 sequence, you can see you've got cord centrally, and then you've got the low intensity CSF, and then you've got something that's high intensity peripherally. Now the key to this case is that it's a little bit unusual. They had had an MRI brain with contrast, I think that about 12 hours before. So I'll just show you that MRI. Shows diffuse dural enhancement and thickening. With very large engorged venous sinuses and a tall plump pituitary. So these are all signs of intracranial hypotension, which is responsible for the current symptoms of postural headache. And so what we have here is a post-contrast, delayed post-contrast MRI, showing presumably something contrast enhancing in the extradural space. So this patient was returned later on for repeat T1 imaging, which shows that indeed those collections are a CSF signal, and that increased signal in the T1 previously had been enhancement. So if we look at the T2 axial, you can see the dura, which is outlined on both sides by CSF. And basically extensive extraaxial CSF signal collections. So this is an unusual case for a few reasons. Postural headache gets investigated with the MRI brain for evidence of intracranial hypotension. It's pretty unusual to image the spine in these patients. And it's a bit of a pitfall. Sometimes when you do something that perhaps isn't done commonly, you don't know what the common imaging appearances are. So the cause for intracranial hypotension can be a CSF leak from, say, a dural tear, and that's presumably the source of the extraaxial fluid signal. But this is a case to illustrate that even though it's a bland collection of CSF, there can be vicarious excretion of contrast into that space. And so it's a potential pitfall in someone who's had a delayed contrast administration, that you can end up with this appearance of fluid which is not iso-intense to CSF, which would be the classic finding. So I'll end there. Thank you very much.